Australia is, there it is, and in comparison to India. So I am part of my team. We look after the entire state of Queensland here, and in our entire state we only have 4.82 million, but here in Delhi, your city has more than my state. So just putting that in perspective for us. Oh. So today there's no sleeping after your cup of tea, okay? So we are helpful to understand the childhood development phases and discuss the impact of serious illness and grief in children as they progress their developmental stages, and perhaps think about how to communicate well with the child and the family in the palliative care setting. So just before I start, it's probably important to note that most children are part of a family and a community, and sometimes I think in healthcare we get worried that we are the doctor or the nurse and that we are the most important people, but in fact it's the child belongs to a family and a community first, and we are just a small piece of this puzzle. The family will know their child the best, and so to take cues from them is often very helpful, and they'll still want to parent their child even in the face of very significant illness. So our job is to help them do that. The cultural and spirituality influences are significant in relation to a child's illness and the perception of sickness that they deal with, particularly for a dying child, and that the healthcare professionals should be led by the family and the community, within the constraints of the healthcare setting, of course, but taking that into account can be very helpful in palliative care. Certainly at home we have a saying that anything is possible. Once you have a palliative care diagnosis, anything is possible. And like Hanif says, it's about, living with the time that you have left, not worrying about so much about the dying. You have to have a plan for that, that's true, but it's all about the living. So if we have a look at infants and toddlers, how do they perceive things? So it's all about them, of course. An infant is unable to think outside of their own self. And so the most important thing for them is their bonding with their family. So at all times try and promote that connection and avoid separation from the infant from their family, because that's what is going to hold the memories for the family for the long term and the most security for that infant. He will lessen his distress no matter what his clinical scenario is if you avoid separation. You want to keep the routines, so if they normally have it, I think someone spoke yesterday about the dreadful doll that's probably, or the rag or the toy that is awful, but it's important that they keep that security item with them, and that if they normally have a bedtime at 7 p.m, they should have a similar bedtime. Routines are what keeps them feeling safe. They do have a very limited understanding of outside self, so if they are bleeding or are vomiting, they'll get distressed by that because they don't understand the concept of the fluids leaving their body. They may have difficulty regulating their emotional responses, and so we've all seen a 2-year-old have a tantrum because they're frustrated or can't articulate the words. It's because their emotional regulation is not developed. It's not because they're naughty or something. And in the height of sickness and illness, the routines are disrupted. You may see this as a more pronounced event. So sometimes it's important for us to reassure the family that this is a normal response in keeping with a not normal situation, because they otherwise are thinking the child is naughty and want to punish them, but it's about trying to help them regulate their emotions. The children will also, at this age, will have no concept of gone or the permanency of that. So the child's pacifier is gone and it comes back at bedtime, it's back again. The father will go to work, he's gone, but he comes back again. So in grief and loss, the concept of the child where the sibling is gone or he's died, they have no sense of permanency. So that means that we have to educate the family, particularly around the sibling or something similar, that the child will, the infant, the toddler will keep asking for the bereaved person, because where is Max? Where did he go? Oh, he's gone, he died. They have no concept of that. They're thinking he's going to come back all the time. So that can be quite distressing for a grieving family if they don't have an explanation around that. And the child will repeatedly ask for the child or animal that has died. And this is all normal. The preschoolers, I do like the preschoolers. They're very curious and they want to ask you all sorts of things. They're curious about their body, which is how they end up in the emergency department with things up their nose, because they want to see where that goes, and in their ears, and so they're extremely curious. And so concrete explanations can be very helpful for them at understanding that the nose is a tube, and if you put the pea or the marble up there, it will get stuck, and it's not a good thing. So you have to help them understand this. So, or at the same time, they also have very mystical or mysterious thinking. So the sibling may think that they had a fight with their sibling, therefore they have wished this illness. Or they stole the toy and the child and they got sick because they stole their brother's toy. So you have to be careful that you listen to the child and what they're saying about this illness or this understanding, because they may have some fears that are not rational. They think there is a monster in the cupboard. They think there is a boogeyman under the bed. So helping them, make sense of that in their world of reality and what they can make sense of. And so mostly their imagination is much more scary than the reality. So explaining to them what the medical procedure will be, like the station talk earlier this morning, you think, the child doesn't need to know all those informations, but it will help because their imagination about what the needle in the back is going to look like. They think it's this ginormous needle and it's going to be bigger than them because they can't see behind them. So if you show them and you use, play to show them, their fear will be reduced quite markedly. Explaining to them why their tumour is growing in their arm and that there's a gather of bad cells. They are such concrete thinkers, they won't understand that means that they're dying from their tumour. They just want to understand why it is a bigger lump. So I think it's helpful to do all this. They're very aware of adult reactions. They're very aware of the non-verbal cues. Even as you as health professionals, you walk into the room, the child has a very terrible wound, and your face is like, oh, what? Or the odour from the wound. They're very perceptive of that, and they will withdraw because they see your reactions. They become very heightened with their parental reactions. They don't understand the gravity of the situation and the permanency of it, but certainly very good at reading the cues. So take care with that. They will begin to understand permanency a little, that if their brother or their sister has died, that perhaps they won't come back. They may have some understanding, but also backwards and forwards be hopeful that the bereaved sibling will come back. So keeping that in mind, that it's okay if they flip between one and the other, and reassure the parents this is normal, that the child doesn't have any mental distress. It's quite a normal developmental phase. And that when the child is very sick and you're trying to talk to them about the possibility they may die, that might be appropriate, maybe not, or the sibling has died and there is grief in the house, that the sibling can only do small amounts of grief. He will come in, be very sad, very distressed, and next be wanting his lunch and we wanting to play in the playground. And that's normal for them to jump in and out so much. I guess, and then also the medical play, like we spoke about. Let them do the lumbar puncture on their teddy bear. Let them see the stethoscope, demystify the equipment that they're using, so that you'll have a better engagement with an otherwise potentially uncooperative little person. So the early primary school, so these kids have a definite more curiosity and they're starting to understand some of the medical language that they may have met. If they've undergone leukemia treatment for a number of weeks or months, they will have an understanding of some of the terminology. They'll be able to understand a little bit about what their hearts and their lungs are and their blood. They may start to have an understanding of the doctor who looks after their blood, the feelings doctor, the physiotherapist. They will start to have an understanding of different medical roles. So feel free to, and they'll have a curiosity. Who are you? What do you do? How come? What for? Particularly if they're medicalised, they will be very curious about your role and what are you doing here, and go away and maybe quite vocal about who they do and don't want to see, because as they understand their roles. Earlier they tolerate people much better. Once they understand you're the physiotherapist and you're going to make them get out of bed, they're not so excited to see you. So I think that's, in keeping with their development. They also now are very into play, and they may play out. They may not have the vocabulary to vocalise their distress. They may have an awareness that their illness is very serious, but give them some modem to play. So some teams have some sand, some might have some plasticine, even the dolls, and they're playing with the dolls. Drawing is also very effective for them. They can draw, and then you can say to them, oh, I see you have done a very beautiful drawing. Talk to me about your drawing. Well, this is my mother and my father, and this is me in the bed, and this is the God, and I know the God will come soon. And so sometimes you can get an awful lot of information by asking them to describe their drawings if they're still able to have this modem of communication. The rituals are very important. So sometimes the siblings, or even in life, if you have had a practice, the pet has died at home and then there is a ritual about the pet's death and you have to put it in the box and there has to be flowers and it has to happen all before the school time, and it all is a ritual of practice. So then when the sibling or the death is seen in the family, they have an understanding and they're very comforted by that ritual. So you can include them in the rituals when the child has died, and again, that's a parental preference, but our job is to talk to the family about this as a normal response and how can we help the family make sense of this as they go forward. The adults in this scenario, in this age group, for the most part, these children aren't usually able to come to you with their words of feelings. They don't necessarily have the description of the sadness, feeling overwhelmed, feeling frustrated. So you might witness their behaviour and you say, are you feeling frustrated? Are you feeling sad of Max's death? And they'll say, yes, I'm feeling sad. And they will take on the language that you use, but they will struggle to initiate those discussions. So sometimes you may have to lead them with the words and the terminology, and then they will be able to forward a conversation. But until they have that, it's a little harder. Versus the next group, when you get into the upper primary school, they will be able to come to you with the description of their feelings, and they will be able to better articulate that. So that's a group that but still, depending on how neurologically developed the child is, it's not so much about their age, it's about how all of the other influences that come into the place. So still an upper primary child, they're needing a lot of detail. They want to know how many milligrams, how many tablets, what will happen exactly, how will I get home, which bus will I catch, which parent will take me. They will drive you crazy with the detail, but they're trying to put the sense of their world together in a much more, they understand they have to go home by a bus. Now they want to know which bus and how long it will take and which parent will carry me. They're starting to get much more worried about the detail, so in your explanation you will have to factor in more time because they will want, no longer will they just want, you have to take this medicine. Well, what colour is it and how many tablets is it and when do I take it? They will want to know this, so be prepared that it might take a little more time to engage this age group, and they will suddenly go from not knowing the detail to knowing the detail. So you might have known this patient for a year or 2 years and suddenly they want to change up, so be prepared for that. They can initiate feelings, like we said. They have a very good understanding of their body, and they're starting to understand the more internal workings. So a reasonable explanation about what's going on for their disease process is very appropriate for them at this point. They do have this understanding. Their peers are very important. And they just want to be normal. They want to get back to school. So disfiguring, tumours and growths and dressings and things are very distressing for them, and you would find it out of keeping with what is going on for them in comparison to other patients. But it's this age group that they suddenly are aware, they don't feel that they don't look the same, they don't feel the same, and they can have a level of distress around this. Perhaps they're quite separated from their peer group due to distance, they've travelled to the hospital. How can you engage them? Perhaps allocate them the bed next to another child of similar age instead of allocating them next to a small child, and the two can talk. So that can be very helpful about where you're placing the patients in a ward scenario or in a hospice. They just want to be normal, and they will now beginning to develop a sense of what death is and that it's permanent. They might actually be having some extreme fear of this because their awareness of what it means is starting to come. And so suddenly they have a great fear that they will experience death and that will be a blackness, or depending on how they describe it. Some kids describe it as a blackness because they don't understand what's onwards. They worry about their parents, they worry about their siblings. They're starting to take on all these new worries. So if you have some counselling, that's very good. Otherwise you may need some time to listen to their story. They're very good at writing things down. They can be still good with drawings, but probably writing or music is also a better avenue, so you can use all these things. And they may or may not talk to their parents, they may talk to a different adult. And for the nurses in the room, that may be you at 2 o'clock in the morning that they want to talk to. So be listening for those cues of the conversation. Like we said yesterday, not just about the machine. If you're listening, they will talk with you. But if you're not listening, they won't. They will try to get your attention. And if you don't engage, they won't ask you again. So be mindful of that. young people, talking with young people is always entertaining, because you're never sure what you're going to get, and you might get lots of attitude, you might get lots of words, they might not talk to you at all, and I guess reassuring families this is a normal process, and you have to work a lot harder to engage a young person. Again, using different mediums, music, writing, using an email. I had a young person ask me, can you help me write an email to my parents because I don't think they know that I'm dying? Okay. So you can, be creative about how you interact with a young person, and it is always unexpected. But if you work hard, the reward is amazing. To connect with a young person who's dying, they'll be very insightful. It is a very privileged position to hear what a young person has to say as they go through a terminal phase of their illness. So just taking care that if you're meeting children who have been very medicalised, sometimes they say the words, but they don't always have the understanding of the meaning. A young child may say, I know I'm going to die, but they're actually just repeating some words that they've heard from an adult. They don't necessarily understand what that means and the permanency. So how do you know this information? What do you mean by that? I am scared I'm going to die. What are you scared of? So making sure you clarify what it is that they're bringing to the conversation, because they may just be repeating medicalised jargon and words they've heard adults use. They will have developed a heightened awareness of non-verbals. They're very smart. They understand if their parents are extra distressed, or you've taken them out for a meeting longer than usual, or the doctors come in and look at them with, some young people will say, they've got those big eyes. That's not good news. So the health professionals come in looking very glum. They know that this is not good. So they're very aware. And how involved is this child or young person going to be in the decision making going forward once you've reached a more palliative state? Taking that into mind, that's about how your relationship is with the child and the family. It's about the family dynamics, how they do things. You're going to mirror how they do things. Maybe their family is open style communication, maybe it's not. So you will know them the best as the healthcare professional involved, and check in with the family how they want to involve the young person. And don't underestimate how much value the child or young person can bring to the discussion, particularly if you're having trouble getting the parents to understand that this is a more palliative in phase. The young person or child themselves can say, no, I understand I'm dying, can you talk to mum and dad? Okay. So you can engage them in that. Or what is the child's wishes if the parents can't agree on escalation of care or de-escalation of care? If the child wants to go home to their rural setting, then de-escalation is not possible. So that can help you with your decision making as medical team. So grief, we won't talk so much about that today, but understanding that children can display grief in quite physical symptoms in keeping with regression to their previous stage. So if a 5-year-old is trouble with bedwetting, that's a normal regression. A 12-year-old displaying bedwetting is not a normal regression and maybe needs some additional support. That's probably the main thing from this. So talking to children, as we've said already, they always know more than you think, but clarify what they're saying to you by questioning them back. Don't make assumptions that they do have a full understanding. Listen for the cues. The nurses, 2 o'clock in the morning, if the patient says to you, oh, what happens when somebody dies, can you donate organs? And if you hear that question, then they are very aware of what's going on and they're looking to you for some more. Why do you ask that question? Well, I am worried that my disease is not getting better. I want to ask these questions, but I'm scared to ask my mother. So, and then what you do with that is in context of, the family, what's the style for the family, and whether the mother is lying there asleep, half listening, is also part of the question. You will expect the unexpected, and you try to avoid time delay. So if you've had a conversation with the parents out of the room, try to engage the child with the update of the information as soon as possible, or they will not trust you quite so much, so take care with that. Avoid protective behaviours, but again, depending on what's culturally and family suitable to that situation. And it's okay to be honest with your own feelings. So, how long will I live for? I don't really know, but I wish we could have cured your disease, and I'm sad that we cannot. And if you're open and honest with your feelings, then the child will take some of that on. At the end of the day, you are a human as well as a health professional. So what can you do? You can listen carefully. Try to stay connected to the child and family, even though sometimes that is very tough for our hearts because we know that they will die now. But if you can stay connected, that's precious. And then, like we talked yesterday, a little bit about self-care. Do you want to use accurate information? Not talking about having a long sleep. He will die, not a long sleep, or the siblings will never have a sleep again because they will be afraid to wake up. So be careful using accurate language. Work within the context of the family. Watch their communication style because that's how you're going to do it. And to take care of yourself, please, because all of this is hard work. It will tug your heart. So we want you to do this for the long haul. So make sure you put some good strategies in place in your own care so that you can continue to do this good work for as long as possible. And thanks, everyone.